Hello, my name is Niklas Nielsen. I'm a physician intensive care at Helsingborg Hospital and Lund University in Sweden, and I've got the honor to talk a little bit about post-cardiac arrest treatment in the future. I have no commercial conflicts of interest for this talk, but I am the principal investigator of the TTM1 and the TTM2 cardiac arrest trials on out-of-hospital cardiac arrest, where we have investigated the benefit of hypothermia. And with that, I also have a conflict of interest that I will concentrate this talk on temperature management and hypothermia, even if it's just a small subset of the cardiac arrest patient's full setup. And the message for today is that we actually have more than 6,000 cardiac arrest patients that have been randomized for TTM and hypothermia with the trials we've performed. So quite a substantial number, but still we have guidelines supported only by low to very low quality of evidence. And I think this actually must be considered somewhat of a failure for the ICU community. We're all responsible for having performed too many small trials and not done the full big trials altogether. And how can we improve this? And I think the only answer we have to this is to collaborate and perform these large RCTs that are required to answer the questions that also can take away a bit of the criticism for RCTs that are often considered too underpowered. If we go back, these 6,000 patients, they have been randomized during 2 decades almost. We have a history of 18 years now, counting to 19 next year. And it started already in 2002 with the familiar Bernard and the Haka trials that really changed the whole scenario for cardiac arrest patients in intensive care. And throughout many years, hypothermia was introduced in country after country. And nothing was really done on the trial market until 2013 when the TTM1 trial came out indicating equal outcomes of 33 and 36 degrees. So taking away the hype for 33, that was from the beginning. And at the same time, we had the KIM trial that indicated that pre-hospital induction of hypothermia with fluids didn't work. So that was a little bit of a blow for hypothermia in cardiac arrest patients, and many thought that we maybe should not use it anymore, even if that was not what the trials indicated. In 2017, the Kierkegaard trial from Denmark came with less patients, 355 patients, but they compared 24 to 48 hours and could actually show a quite strong signal that 48 hours was better than 24, but it was not a conclusive trial. Same with the Princess trial from 2019, 677 patients, also pre-hospital induction, already during resuscitation. Also, again, an inconclusive trial with neutral results, even if there are signals within the trial that could be interesting. The first trial that actually was positive since the Haka trial and the Bernard trial were the Hyperion trial from last year, Jean-Baptiste Lascaroux in France, 584 patients, where they showed that 33 degree patients had a better outcome compared to 37 degree patients in non-shockable cardiac arrests, a patient group with very grim prognosis. But also, this was a bit of an underpowered trial, quite frail results that could be discussed. So it doesn't really give us the answers that we need. And then next year, we will have the TTM2 trial coming up, the Dankiewicz trial that will be called with 1,900 patients, and I will come back to that. We still have the 2015 ERC ISICEM guidelines out. They have not been changed, where hypothermia is strongly recommended for shockable rhythms in out-of-hospital cardiac arrests and weak recommended for non-shockable out-of-hospital and in-hospital cardiac arrests, and strong recommendation to target 33 or 36 degrees if you choose to use hypothermia. But again, based on low to very low quality of evidence. And this has not been changed since the TTM and the KIM trials came out. The new trials have not impacted on the guidelines. And we will see the 2020 guidelines are a little bit delayed due to the COVID pandemic, and we will have next year's guidelines hopefully influenced by the newer trials. If we look at Sweden, we can just see what happened after the publication of the TTM-1 trial in 2013. You can see an absolute change, a switch from 33 to 36 almost overnight. That was almost 100%. That was Sweden. If we look at the outcome, it has not changed between these two groups. The outcome is still on 47% survival, with a p-value, as you can see out in the right part, almost at 1 or at 1. So no difference after the change. Quite a few reports from many parts of the world, single centers, multiple centers, registry data with conflicting results after the TTM trial came out. Some indicating better outcome, some indicating worse outcome after the change. But what has been the summary of this is that it's quite weak evidence for any substantial or robust change in survival or outcome after the change to a more scattered way of handling temperature management. The two better studies, this one from the United States, show a clear drop in the use of therapeutic hypothermia after the TTM trial came out in 2013, as you can see on the x-axis, both for VTVF and PEA and asystole. They report a trend towards less survival, but when they analyzed this into depth, they could not see that this was mediated by the change in temperature management. So it's probably something else that has produced this change. But it warrants further analysis, of course. A little bit more worrying is from Australia and New Zealand, where you can see on the top graph that the temperature has changed for ICU patients that are treated with cardiac arrest. A dramatic change when the TTM trial came out. You can see a sharp increase in temperature, but you can also see a slight tendency to an increase in worse outcome compared to the gradual decrease that we've seen for the last years. So maybe that's an indication that at least people tend to have a more relaxed attitude towards temperature management, and maybe not reading what was really said in the TTM trial, that both groups, 33 and 36, got very strict temperature control. With all these different trials, studies coming out indicating that we today give, according to guidelines and outside of guidelines, temperature management to cardiac arrest patients, I think many await the results from the TTM-2 trial, where we will compare hypothermia or early treatment of fever in 1,900 patients. The trial was finished this spring, and follow-up has just been completed, and the analysis phase will start this fall. And if you look at the HACA trial from 2002, we tried to mimic the temperature graph for that trial to have a follow-up on the trial that really introduced hypothermia in the first setting in 2002. So we've designed the protocol to mimic the HACA trial with a faster induction of hypothermia in the 33 arm. Different from the HACA trial, we introduced an upper safety limit, 37.7, and above that we introduce targeted temperature management also in the upper group to avoid fever, to avoid the really high temperatures. There are 3 possible scenarios of the TTM2 trial: benefit of 33 degrees, benefit of targeting normothermia, and no difference, a neutral study. And in scenario 1, benefit of 33, I think we have to consider the results of the TTM1 trial, where 33 equaled 36, and the TTH48 trial, where the trend was towards better outcome with 48 hours. And the most logical study we could think of at that time would be to do a 2x2 factorial design of 33 versus 36 and 24 hours versus 48 hours in a sufficiently large sample size of about 3,000 patients. In scenario 2, the benefit of normothermia, the logical next step would be to challenge temperature management per se. Is fever harmful, or is it just an epiphenomena? And I think we should perform a large pragmatic trial of temperature management versus no temperature management. Also 3,000 patients. In scenario 3, with no difference, I think the most logical thing would be to meta-analyze these results with the data from the Hyperion trial and also with the TTM1 trial, and decide on the definite trial arms after these results are known. And the most probable trial would probably be similar to scenario 2, where we compare temperature management versus no temperature management. 3,000 patients. So for the future of temperature management, I think we should do the relevant large RCTs in collaboration. We may have to go back to the bench and perform new animal trials, clinically relevant models. We need to investigate the benefits of fever control. And it may be time to again focus hypothermia on the very early phase, already during resuscitation, if that is feasible. It's complicated, but it could be done with perfluorocarbon, ECMO, or other immediate cooling. So the future is for continuing to investigate this field. And with that, I would like to thank you so much.